So Mark has told you what's in it for you. We have the potential to actually save lives for the septic patients that come into the emergency department. And I want sepsis to be an emergency department disease. It is not an ICU disease. We get to see them first, and we have the most potential during those first few hours to actually alter patient outcome. So same cheesy slide. So I'm Scott Weingart. I'm the Director of Emergency Critical Care at Mount Sinai and Elmhurst Hospital. I'm both an ED guy and an intensive care guy, dual trained, so hopefully I can provide you some tools to bridge the gap between those two arenas. I'm taking money from no one. The lactate companies aren't paying me. Eli Lilly's not paying me. So what you're hearing are my opinions. And that's an important thing to talk about in the sepsis care world. There's been a lot of controversy about outside influences being what shapes the ideas and care for sepsis. This whole collaborative, its sole purpose is to make care for the patients in New York and the surrounding areas better. All right, we're going to talk about two things. We're going to talk about recognizing the patient with severe sepsis, and we're going to talk about treating that patient. Recognition is probably the harder thing to do. You have to find those sick patients. Now, if you look at all the ED patients that come through your door every day, and that number just keeps growing every week, we're talking about a small percentage of them who have the SIRS criteria that Mark mentioned just a few minutes ago. The main thrust of the initiative is not even those SIRS patients with an infection. The ones we really are looking at for this collaborative are the severe sepsis and septic shock patients. But narrowing down all the ED patients, even to the SIRS patients, and then further to the ones with severe sepsis and septic shock is tough. And the real problem is we're not looking for those patients as assiduously as we should be. And the patient we're really looking for is not the guy crashing with a blood pressure of 60/20 looking like death. We find those guys pretty easily. It's what we call occult or cryptogenic severe sepsis that we're really worried about. And these are the folks who have good vital signs. They might be a little bit tachycardic, maybe they're a little bit tachypnic, but they look otherwise okay. You almost might look at them and say this patient might go home. They have some of the SIRS criteria, but they might be smiling in bed. And for the most part, we ignore those patients until they force us not to ignore them. But those folks are actually ticking time bombs. These are the folks that if they're showing signs of poor organ perfusion, before they manifest them in the hemodynamic markers, these folks actually go on to die, but have the most chance for reversing their outcome if you treat them early. These occult septic patients are our primary goal in the recognition portion of this initiative. So how do you find those guys? Well, probably the best thing we have to date is a serum lactate. Now, how many folks are sending lactates routinely in their ED? Show of hands? All right, so most. How many folks, if you had someone at triage with a pulse of 102 and a fever of 100.8, otherwise looking well, would send a lactate on that patient? All right, many, many fewer hands have been raised. So now we know one of the goals of this collaborative is to get every ED sending lactate on that exact patient. Now the reason is lactate, when it's greater than 4, is associated with a dramatically higher mortality, both in septic patients and pretty much in any patient population you look at in the ED. So this is a marker that has prognostic significance for our patients. And beyond that, it actually is a marker of treatment, because if you take those patients with the elevated lactate, give them good resuscitation and bring their lactate down, that's associated with lower mortality. So this is it for recognition. We can recognize already the crashing patient. Now we have to recognize the ticking time bombs. And the way that we're going to do that is with lactate. So in order to make that happen, we're going to give you a tool. Now the thing is, with all these tools we're going to offer today, they're for you to take back and adapt. If you look at it and say, this is not going to work at my hospital, that's fine. You might have particular things in your institution that's going to make something work better. Take these tools and adapt them however you like. They're there for you. So open up your packets and take a look at the severe sepsis triage screening tool. All right. The goal of this is to be used at the triage desk or triage room, however it works in your ED. And As the patient's being triaged, and I apologize to the triage nurses for adding one more burden to what I imagine is already a miserable experience, because that's how it is in our shop. I apologize, but this is good. This is going to save lives. So you're going to look at your patient, you're going to ask them if they have any three of the following. And these kind of look similar to the SIRS criteria that Mark had mentioned. The thing is, you don't need any lab tests back for the ones we're looking at right here. So they're triage ready. So does your patient have a suspected infection? That's Gestalt, whatever you think. If they have a cough and it's productive of yellow sputum and you think they have an infection, there you go, it's answered. And don't spend too much time on this. Just you have clinical experience as triage nurses. They're some of the best people for knowing what's going on with a patient. They oftentimes can look at a patient for 20 seconds and already know what that patient's diagnosis and treatment is going to be. If you think they have an infection, the answer is yes. All right, temperature, it's objective. Either too high or too low. Or are they rigering? And again, that's subjective. Use your judgment. Are they tachycardic? And we put a pretty low threshold here, 90. Respiratory rate greater than 20. Any alteration of mental status. A low oxygen saturation on room air. Or a low systolic blood pressure. I see your question, and please, throughout all this, ask questions. Now, you look at that and you say, this is insane. This is half the patients that come to the ED. It's probably not that high, but you're right. Your point, has been made by many folks on the advisory committee when we were talking about this. The idea of this is to be all-inclusive. When you see what this is going to trigger, it's very minimal. It's probably what any patient looking like this is going to get anyway, except the addition of a lactate. Now, the question becomes, are we going to start sending lactates on too many patients? That was the fear in our hospital when we first started. And the answer is, you can't send lactate on too many patients, because for the most part, if it's sent, it's going to be negative in a non-sick patient. It's going to be positive in a sick patient. I've never had a lactate sent that I look back and say, God, I wish that wasn't sent. That forced me to do something I wasn't going to do anyway. It doesn't happen. It's not going to play out like that in your hospital. Now, so let's look at that triage order panel, what this is actually going to trigger. So you're going to notify your clinicians to put a verbal order for this panel. And that's all dependent on your hospital, whether they'll let the triage staff initiate orders without talking to a clinician. If that's the case, great. You don't need to talk to a clinician at all at this point. You're going to send a CBC, whatever metabolic panel you like. You're going to send a lactate. And that's either venous or arterial. I imagine at triage, they're going to be venous. Preferably, it's going to go on ice and get sent rapidly. Studies have shown, Jeff Klein's group showed, if it waits a little while, it's okay. If it's not the first lab test drawn, it's okay. The numbers are still going to be accurate. So just get the lactate sent. You're going to draw and hold coagulation panel, draw and hold blood cultures, and you're going to start recording vital signs every 1 hour, because this patient has the potential to be sick. Now, your question, sir?
In terms of increasing the yield in the triage process, I kind of run around with portable capnography. Can I repeat the question?
I will. As soon as it's clear, I definitely repeat it.
To try to increase the yield on appropriately assessed vital signs, I kind of run around with portable capnography.
So the point was that in order to increase the yield, they were going around with a capnography device to increase the yield. Now, is this a exhaled gas capnographer or an actual tissue capnography? What's that?
It's a side stream.
Side stream. And so you were looking for end-tidal CO2 as a marker of?
Yeah, no, I just try to get a more dynamic respiratory rate.
Oh, okay, great. So his point was he has a device, it's a exhalation capnography device that actually will give a real objective respiratory rate as opposed to the subjective ones. And that's great if you have that in your process.
The other thing is, in terms of ISTAT, bedside serious.
Sure. We're going to talk about that later on. Right now we just want one, and his last point was they actually have point of care lactates, and if you have that, fantastic. And this initiative might be...
I've been a proponent.
Okay. So this initiative might be a way of pushing your hospital to get point of care lactates. It really cuts the time to getting your results back. All right, so this lab panel sent. I see a question in the back. That is a fantastic question because it allows me to make my favorite statement. There was never a happier moment in my life as when I graduated residency and never had to treat another sick child. They scare me. I don't want to deal with them. I have no knowledge of them. This is an adult initiative. So anything I say, anything that you hear during this day is for adults. Now, I think it is readily adaptable for peds, but I do not have the knowledge to make that happen. And maybe that will be another step in this initiative, is to bring the peds people on board and try to expand to that population as well. But everything we're talking about right now, 18 and older. All right, any other? Yes, ma'am. Sure, how many EDs have point-of-care lactates? Not too many. And I'll tell you, I'm associated with two systems, Mount Sinai and Elmhurst. Mount Sinai has it, Elmhurst doesn't. It makes a big difference. It doesn't make difference just for this lactate. You get point-of-care electrolytes for that potentially crashing hyperkalemia patient where you're not sure about the EKG. You get the sodium on that obtunded patient and find out they're profoundly hyponatremic. So there is value. Maybe this can make it happen. All right, the last part of this triage screen is the question, is the patient's systolic blood pressure less than 90? Is their MAP less than 65? If it is, tell a doc, an NP, or a PA, and get this patient seen more quickly. This patient potentially is already in septic shock, and what that clinician is hopefully going to do is they're going to expedite care. They're going to start 2 liters of crystalloid right away, pushing it in quickly, not the 100 cc's an hour that Mark was alluding to, and get this patient treated. And that's going to allow us to further clarify this patient's condition for what we're going to talk about in a little while. All right, so any other questions about the triage screen?
Why can't you substitute bicarb measurement for lactate?
So I'll answer that twofold. The question was, why can't you substitute a bicarb measurement for the lactate? The first answer is that when Rivers' trial looked at that exact question, the bicarb did not match the patients who had lactates greater than 4. The physiologic reason is there's a lot of other things going on that are going to influence that bicarb. And if you start hitting this patient with normal saline, or they received it in the ambulance, they're going to get a hyperchloremic acidosis that's going to potentially skew your bicarb measurement as a marker of this. So you're both going to overestimate and underestimate patients for having severe sepsis. Every time they look, trying to use base excess, trying to use bicarb, it didn't play out. You got to use lactate. Lactate has the most evidence behind it for prognostic and diagnostic purposes. It's the test you want. Now, most labs are running this on ABG machines in the lab. So the turnaround for this, in contrast to bicarb, should be less than an hour. And that really is one of the quality things you should be looking at independently. We're not looking at it as a initiative-wide data point, but you probably should be looking at your lactate turnaround and making sure it's less than an hour. Yes, sir.
Yeah, we've been using lactate in trauma for 15, 20 years, and we have, increasingly sophisticated shock panel type blood gas machines that will automatically crank out a lactate along with the blood gas. We still have retrograde individuals who occasionally will get blood gases, but in patients like this, if you have one of those machines, you automatically get a lactate when you order a shock panel. And if we're serious about this initiative, I think that ought to be generalized.
Absolutely. So the point made was that for trauma, they have a shock panel that automatically includes a lactate. Very well, it might help you to have a sepsis panel that includes these labs and a lactate. But for whatever it takes to get this done, it has to be done. Your hospital needs to be able to get you lactates in the ED rapidly. And it really is beneficial throughout the house to have access to early lactate. All right, so how do you get the lactates done? Well, hopefully it's going to get done at triage. That's the goal, is to have this become part of the triage mentality. And it took a little while. It took about a year in our shop to get the nurses and the docs understanding why we're doing it and how it's helpful. And the fact that patients that don't look sick are probably the most appropriate recipients of this lab test. So it's not an overnight thing. I see your question in the back. But when you work towards it, it starts to happen. Now, I'm going to give you some prompts that we use to make it happen with more regularity. So on the blood culture draws, on every blood culture draw in our ED, we have a sign saying, if you're sending blood cultures, consider sending a lactate as well. Because blood cultures are a marker of a slightly more ill infectious patient. You generally don't send blood cultures on your strep throat in your fast track area. So if they're sick enough to need blood cultures, they're sick enough to get a lactate. Another thing we've done is we made lactate greater than 4 a panic value in our ED, which means we don't have to go back and keep checking the computer to see if these patients have signs of severe sepsis, because the lab is actually calling us. Now, I hate lab panic values. They're annoying as heck. In fact, the one I get most commonly is on a Friday night, I get panic values for alcohol levels of greater than 500, which for me, the panic value on that obtunded, drooling patient would be the alcohol value of 0. But I can't argue with them. It doesn't. This one actually helps. The panic value, lactate greater than 4, really makes a difference, because I know instantly, as soon as that lab tests back, I have a sick patient who probably is in the general ED area not being cared for. All right. If you have an electronic health record, you could add prompts for this stuff. Prompt the clinicians when they're ordering blood cultures to order lactate as well. Just have a little pop-up. It says, ordering blood cultures, order lactate. If you're admitting a patient with a diagnosis of UTI, pneumonia, sepsis, urosepsis, fever, a prompt that says, did you send a lactate, is a really good thing. These are some of the things that work for us. As the initiative goes on, hopefully I'm going to hear back from you folks on things that work for you to get the lactate sent. Now, I saw a question in the back. Yes, ma'am. We're going to talk about data collection a little later in the afternoon, so that question will be addressed. But basically, the short answer is whatever works for you, as long as the very brief summary of the data from the hospital is going into Greater New York, whatever works for you as data collection on the individual patient is just fine. All right. Now we're going to move on to, once you've recognized these patients, how you actually treat them. So you found them, they have a lactate greater than 4, or they were hypotensive, and you gave them 2 liters of fluid and they're still hypotensive. How do you treat these patients? This is now that small circle. The severe sepsis or septic shock patients, these folks have a very high mortality. About 1/3 of them will die if you look in some of the studies. Bad stuff. So how are you going to treat these patients? You're basically going to treat the source of infection and you're going to perfuse the tissues. And if we just left it there, you'd be doing okay. But you probably want some further clarification. This protocol we're going to discuss is my primary reason for wanting to be part of this initiative. In 2001, Emmanuel Rivers published a game-changing paper on the care of the septic patient in the ED. He published an early goal-directed therapy paper. It just changed the landscape. When I was training as an intern, I remember looking at these sea of septic patients, and the standard treatment would be 500 cc's of fluid, because you didn't want to put them in pulmonary edema, start them on dopamine through a groin line, give them some antibiotics, stick them in a corner until those ICU guys could get to the patient. That was it. And you guys might remember, and God, I hope not, but maybe that's still going on right now in some EDs in the country. After Rivers' landmark paper, the concept of aggressive care in the ED became a reality. It became a reality, unfortunately, in the hypothetical sense for the most part, though. People talked about it, they thought about it, and they didn't generally do it. And when you ask ED directors why aren't you doing early goal-directed therapy? Look at the papers published on why. Ask people in your own hospital network, why is it not getting done? The most prevalent answer I've found, and you folks could tell me if you disagree, is we're not going to stick a central line in a patient that looks fine. All right? How many folks agree with that statement? Who's in ED? All right. Any other reasons from the audience why early goal-directed therapy is not getting done? Yes, sir.
Advanced directives.
Okay, and we'll address that. Martin mentioned advanced directives. That's a good reason for early goal-directed therapy not to get done. And the other reasons we found were it's a lot of work. And generally, folks don't like work that doesn't give back. So if you have a situation where you're having door-to-needle time for cath, that's one the hospital's forcing. They haven't forced this issue, so there's no negative feedback. And then no one really comes to you and says, hey, good job on that guy you gave the 4 liters of fluid to. He wound up not dying in the hospital when he would have otherwise. So there's not the positive feedback. So no one's pushing this issue. It's easier just to let them go up if their vital signs look good. But what if there was a way to do this that didn't take an incredible resource burden. What if you didn't have to stick a central line in these patients if they looked otherwise well? What if you could do this non-invasively? Alan Jones published a paper about a year ago now that compared the use of lactate to the use of a central line and central venous oxygen saturation, that invasive side of septic care. And they were the same. And that allowed the formation of a non-invasive protocol for severe sepsis patients. So why don't you turn to that? It looks like this. And we're going to go through this step by step. All right. So you start off with who this protocol includes. And so you got a septic patient. So they had SIRS criteria. You sent the lactate. The lactate was greater than or equal to 4. Or they were hypotensive. You tried some fluid resuscitation. You gave them about 2 liters of crystalloid. And they're still hypotensive. Either of those patients, you get into this protocol. And then you ask the question that Dr. Warshawski alluded to, which is, what are your goals of care? And this should be a big stop point for you, because this was not built for the patient who never wanted to be on a ventilator, never wanted aggressive care. It wasn't built for the 97-year-old in a nursing home with dementia. This is built for patients who have goals of care that are curative. So if you get to that point, you have a patient, you have aggressive goals of care, and they have severe sepsis, then you move on. First step, give another 2 to 3 liters of fluid. If they were hypotensive to start with, you're giving on top. If they had the elevated lactate, this might be the first fluid they're seeing. But you start the fluid early, because as Dr. Rosen was mentioning, fluids are one of the most important things for treating a septic patient. All right, you culture all your likely sources, and that includes paracentesis for suspected peritoneal infection. It includes an LP if you think they have meningitis. You know the drill on this. This is just good ED and ICU care. You think about source control, which is alluding to the fact that all the antibiotics in the world don't take care of a pus-filled gallbladder, and they don't take care of an infected central line. So those have to come out. You administer antibiotics to cover all likely sources. Now, as part of this initiative, if the members tell us they need it, we'll develop standardized antibiotic plans. But the better way of handling that is to go back to your hospital, look at their individual susceptibility data, and actually create some antibiotic paradigms for empiric treatment in the ED. Now, if this is going to work, if you're going to get those antibiotics in less than an hour, then you need to have those antibiotics available in the ED and not have to call pharmacy and have them sent. This is another thing you have to go back to your hospital and make happen. All right, now we come to fluid resuscitation. You're going to choose one of these 2 strategies. The one I prefer is ultrasound. How many folks have ultrasound machines in their ED? Perhaps I should ask, how many folks don't have ultrasound machines in their ED? All right, just a couple, which is fantastic. How many folks are using ultrasound to look at the inferior vena cava for fluid responsiveness? All right, a few. And how many folks have never heard of that before today? All right. So hopefully we have the ability then to use ultrasound for IVC measurement. I'm going to show you how in just a minute. Let's say you didn't have ultrasound. Let's say you had ultrasound, but you weren't comfortable with it. Let's say you had it, were comfortable with it, but this IVC thing seems crazy. You don't think you could do it. In that case, what we'd recommend is empiric fluid loading. Now, there is a trial out there called the PROCESS trial, NIH-supported, big multi-center trial trying to prove if early goal-directed therapy works or not. In one of their groups, they're doing empiric fluid loading. The way they're doing it is they load fluids until the patient develops pulmonary edema. It's not a bad strategy. It'll get enough in. I don't think we need to go that far. But if you are going to use empiric fluid loading, you have to understand it's a lot of fluid these patients need. When I looked at my shop, about 6 liters was the average. Manny Rivers' trial, 5 liters. They're pretty much always right around that ballpark. So it's not 1 liter, it's not 2 liters, it's not 3 or 4. It's generally going to be in the 5 or 6 range. So if you're going to decide to do empiric fluid loading, you should think that that's probably the amount they're going to need in those first 6 hours of care. Now, let's say you had the ultrasound, you wanted to do this more objectively. Let's see how you could do that.
My name is Daniel Duquette, the ultrasound director on the Ultrasound Spice Center. And I'm going to be demonstrating proper technique to visualize the inferior vena cava.
All right, so what Danny's doing here is he's just taking a curvilinear 3 to 5 megahertz probe. He's aiming the indicator towards the head. He's placing it just under the xiphoid process, and then he's just sliding 1 to 2 centimeters to the patient's right. So that's the deal. Probe goes just under the xiphoid. Slide 1 to 2 centimeters to the patient's right, and you just tilt towards the heart. So let's go through the normal anatomy you'll then see on your ultrasound screen. So what you see is you see a IVC, the black thin-walled structure underneath the liver, and you're getting just a cut of the heart, the right atrium. And that's key. That's the proper position when you have just a little bit of the heart there. All right. Now you see that arrow? That's measuring 1 centimeter past the hepatic vein towards the patient's feet. That's where you want to look at the IVC. If you can't see that, then you just go about 2 to 3 centimeters from the heart border. So just to review that anatomy one more time, that thin black vascular structure is the IVC, liver's on top of it, and you're getting just a tiny cut of the heart. About 1 centimeter past the hepatic vein, or 2 to 3 centimeters from the heart edge, is where you look at the IVC. This IVC is collapsing nearly completely, but anything greater than 50% is a patient who's going to be responsive to fluid. So that's been the most validated number. If the IVC collapses more than 50%, give them some fluid. I would tell you if it's greater than 30%, which is really what you could easily see with your eye, I would probably, in most cases, give them fluid. So if you're really seeing any significant collapse, then the patient needs fluid. All right, we gave that patient 4 liters of fluid. Look at the IVC now. No respiratory collapse. If we look just past the hepatic vein, that IVC is not collapsing with respiration. It's staying pretty much identically sized throughout the respiration cycle. This patient doesn't need fluid. All right, another patient who has near complete or certainly greater than 50% collapse of their IVC with respiration. Patient needs fluid. All right, we gave that patient 2 liters. We take a look at the IVC again. It's bigger, but it's still collapsing greater than 50%. More fluid needed. Here's another patient that needs fluid. IVC collapsing just past that hepatic vein with respiration. All right, we gave that patient 6 liters of fluid. Look at the IVC now. No respiratory collapse, staying just about the same size. All right, just one key point to understand about all this. Fluid unresponsive does not mean fluid loaded. All right? It just means the patient is not going to increase their cardiac output with fluid. That's what the collapsing of the IVC tells you. Sometimes you'll have a patient with negative inotropy secondary to their septic state who will not be fluid responsive, and their IVC will not collapse. But then you give them some inotropy with some calcium or dobutamine, all of a sudden their heart's pumping better. If you look at their IVC again, it will start collapsing, and that patient then needs more fluid. All right, so any questions about that?
Scott,
Yes.
what about measuring the IVC?
Sure. So we wanted to make this as easy as possible. So we kept this as something you could just put the probe on. David's question was, what about actually measuring the IVC using calipers? And you can do that. The dynamic changes to respiration have actually been shown to be better correlated than any absolute size, and it takes an additional amount of time to go and play with calipers. So we're just having you eyeball the IVC. If it looks like it's collapsing, give them fluid. And I would always err on the side of anything like this to give too much rather than too little. So I don't even care if you measured the amount of collapse. If it looks like it's collapsing, keep giving them fluid. The IVC will expand to become non-collapsible before the patient gets pulmonary edema. So we're actually still better than that process trial in terms of not over volume loading the patient. Does that answer the question, David? Yes, ma'am.
How quickly do you infuse the fluids? The recommendation was 20 to 30 mLs per kg or 6 liters within the first 6 hours. Is it done over an even time?
I'll tell you how I play it. And the question was how quickly you're infusing the fluid. If I'm using the ultrasound, then I have an objective marker that this patient's still volume down. So I will give that fluid quickly because I know they need it. So I will pressure bag in a liter of fluid each time the ultrasound's showing collapse until I don't see it. If you're doing empiric fluid loading, maybe you want to see a slightly slower infusion. I would give a liter every half hour, 20 minutes to those patients and see what they do. And then you're using clinical markers. And unfortunately, clinical markers aren't great. This is a distant second to what I would love to see, which is an objective way of actually measuring this. So if we go back, you're going to choose one of those two strategies, either dynamic ultrasound or empiric fluid loading. Any other questions before I go further? Yes, sir.
How frequent are you doing the IVC ultrasound?
So what I'll do is I'll put a liter of fluid in, pressure bag. That'll take about 20, 30 minutes, depending on the size of your IV, depending on how high you put the pressure bag. And then when that liter's done, I'll go back and actually put the IVC ultrasound back on. Now sometimes when you saw that IVC that was like really collapsing and so narrow, I could tell you right now, that guy's gonna need 3 liters before I'm gonna see anything significant. So on that patient, maybe I'll give 2 liters before I go back, put the IVC ultrasound back on. But the nice thing about this is it doesn't cost you anything except a little bit of time to get the ultrasound machine. Yes, sir.
A good algorithm for non-surgical people and doing fluid is think like a surgeon.
So
Mark and I, at different stages, came out of Mount Sinai, which is a very strong medical dominance in many ways. And a lot of people there did do what he was joking around about, giving 100 cc's an hour of saline. I mean, you were there also. And that's the fluid bolus. But what he said is exactly what any responsible grown-up surgeon would have said about how to give fluid. And that is how to do it. And it may be very shocking how much you wind up with eventually, and you may somewhat regret it, but better have a live patient where you regret how much fluid you gave him than a dry, dead patient.
there you go. So the point made was surgeons have always done the work wet, and I trained in surgical intensive care. We were a wet shop. I like fluids. It never was an issue for me. So we just have to get those medical guys on board too. Yes?
Any issues when someone's already intubated on positive pressure ventilation?
We will talk about that because in my mind, if you've already intubated them, you really should be on the invasive protocol, which we'll talk about in just a minute. So the point is well taken. Yes?
Can you just address the issue that comes with our hospital about the antibiotics? We have sort of like an unwritten policy that they have to be given sequentially, and obviously we'd like to have them given simultaneously.
Yeah, this is an issue for our place as well, and I might defer this to some of the nurse managers because they have their own protocols. I think it's in the patient's best interest to ignore the very small chance of having a reaction from multiple antibiotics, and because the Kumar study that Mark Rosen showed you wasn't having one antibiotic on board within that first hour, within those first 2 hours. It was having all the antibiotics necessary to treat all of the patient's available sources for their sepsis. So really, if we take that to heart, we want to get antibiotics in as quickly as possible, which means not letting Vanco run for an hour before they get their ceftriaxone, or as the case may be, whatever antibiotics you're using. So I would think giving them sequentially would make a lot more sense. Most of these antibiotics can actually be given by, a rapid bolus without any problem. That's how the anesthesiologists do it in the operating room. Some of them, it's a problem with rapid infusion, but putting them in quickly, sequentially, doesn't make much sense for that. Yes, sir.
Yeah, before you infuse them rapidly, they have to be available. And Mark alluded to that by talking about having them on the shelf. But as we all know, with proper medication identification being one of the national patient safety goals enforced on all of us by the Joint Commission, we ran a QA thing. In fact, our critical care nursing boss, Judah LaFleur, who's out in the audience somewhere, got after them. Now, she's American. She was born and raised in Guyana, but with the way you study the differences with pharmacists in Guyana is with a cutlass. She got after them with a cutlass, and now we have them in the Pyxis. So from the Pyxis, you don't have to worry about ID approval. You don't have to worry about 3, 4, sometimes 6 hours delay in pharmacy furnishing stacked drugs, which I'm sure everybody here has run into. And you really do have them available almost instantaneously. It may take a little, fast footwork to get them in the Pyxis in your hospital, but once it's done, it's a...
Absolutely agree. So having them in the point of care is absolutely necessary. I see the question in the back. I'm going to go on to one more section, and then I'm going to come right back to you. All right. So we've given fluids. Hopefully we got in these patients adequately volume loaded. And I can't repeat enough, it takes a bunch of fluid to do that. So now we're going to recheck the map. Now, hopefully, if you've adequately fluid loading them, their map is now greater than 65. In some cases, it won't be. If their map is less than 65 after good fluid loading, which means a significant amount of fluid, then they're going to need vasopressors, which means they're going to get a full sterile central line. Now, I could get down on my knees and beg you, if you're in the ED, to just do a full sterile IJ or subclavian vein line. That's what should be happening. It's just not fair to the patient not to do that. And that means full drape, everyone gowned, masks, hats, the whole bit, just as if they were going in the operating room. That's how it should be done. IJ, subclavian, full sterile. And please, if you have any potential to do that, do it. We understand some places it's not going to happen. We want this to be an all-inclusive protocol. If you have to put the line in the groin, put it in the groin. In fact, in some ways, I'd rather a dirty line, if it has to be placed, go in the groin, because then the ICUs will definitely take it out and put a clean line in the IJ, as opposed to the stealth death where you claim it was a sterile line in the IJ and it wasn't. And that's the real way to kill a patient, is that stealth death. Because then the ICU, if they trust you, will not change that line, and that patient's going to have a line infection. So do it full sterile, or just do whatever you could do and make sure the ICU changes it out. Start them on vasopressors. I also like norepi. We're not pushing any particular vasopressor. Use whatever you're comfortable with. If Mark's going to come around and check, he'll tell you you're silly to be using dopamine. If you're doing this, if you're going to stick a central line in the patient, you might want to consider switching to the invasive protocol, which we'll discuss in a sec. All right, so now you're at a checkpoint here. You're going to see if the job you did was successful. So you're going to send a repeat lactate. If the lactate has gone down by more than 10%, by 10% or more, patient's done. You've succeeded. You don't need a central venous oxygen saturation. You don't need to go back and look for other things for the purpose of this protocol. You're done. So if the lactate was 4, comes down to 3.5, done. Lactate was 3.2, it's now 2.2, you're done. If the patient was hypotensive and their lactate was never high in the first place, and their lactate stays less than 2, and they're now normotensive, you're done. So this is going to be a majority of your patients if we look at studies like Alan Jones. It's kind of weird. In the Manny Rivers protocol, a lot of patients got to this point and still were underperfused. In other trials, like in Australia, like in Dr. Jones' trial, which I believe was in the South, most patients, they got enough fluid, maybe they got put on some vasopressors, their lactates cleared, they were done. It's going to depend on your patient population. At Elmhurst, a lot of patients still have elevated lactates at this point. It's probably a result both of ethnic variation and the fact that our patients at our shop, at Manny Rivers shop, don't come in until they're near dead. So they're much further along in their septic course than patients that probably have more access to health care and aren't working 4 jobs as illegal immigrants. Yes, sir? Sure. So really, it's when you reach these goals. But if you've forgotten about it or it just was off the radar, I certainly would like it to be sent within the first 6 hours. And I'd certainly like it to be sent before the patient leaves the ED. So if you're realizing the patient's going to go to the ICU and you haven't sent a repeat lactate, maybe you haven't gotten them fully volume loaded, probably worth it to just send one right before they go upstairs so that the ICU has some idea of where they're at. And I'll take the question from that gentleman in the back. There is a potential role. The question was, is there any role for tissue perfusion monitoring, like the thenar eminence, tissue oxygen, like some of the near-infrared red spectrum devices? The answer is yes, in a research role, or if you're using them in your institution, that might substitute for that, but not as part of the collaborative because they're just not proven yet. But I would certainly add them, if you have them, to whatever protocols you're using. Yes, sir? With renal failure? Liver failure. Okay, and it's an excellent question. Lactate will still be cleared. It actually is cleared by the lungs and by the kidneys in these patients. Their lactate clearance should still occur in spite of their liver failure. Now, if you have combined liver failure, renal failure, those folks are a little tougher to deal with. Those are the kind of folks you might want to be on the invasive protocol. You have anything you want to add to that, David or Mark? No? Okay.
Yeah, for those patients probably should be invasive.
There you go. So we're in agreement. Those patients are tougher. They're the ones you might want to get a central line in and be doing dual monitoring, which we'll talk about. All right, let's say the lactate hasn't cleared. What are you going to do for these patients? Well, first one I think is easy. If their hemoglobin's less than 7, they probably deserve some blood. That's pretty non-contentious, both for the ICU folks and the ED folks. If you did the empiric fluid load, maybe it wasn't enough. Maybe give another liter of fluid. And for all these, you're going to do one of them, you're going to send a repeat lactate, see where you are. All right, maybe if you have ultrasound in your ED and you throw it on the heart, and you see the heart is, instead of beating like this, which is what they should be in a septic patient, nice and hyperdynamic, they're kind of doing that. And that probably is from the sepsis itself. The cytokine storm actually causes cardiomyopathy from the sepsis. If you see that patient, make sure their calcium's okay. If not, give them some calcium, because that'll help. And if they're still kind of have that boggy heart, then give them inotropes, and then recheck your lactate. We prefer dobutamine. You're going to titrate it from about 5 to 20 micrograms per kilogram per minute. And I actually titrate it by echo before I even resend the lactate. I want a nice beating heart, and at that point, I'll send my repeat lactate. A little more contentious, and it's out there as an option, not as anything we're demanding. If the patient's hemoglobin's between 7 and 10, they're not clearing their lactate, especially if they're old or they have coexistent cardiac disease, maybe consider transfusing those patients. But I don't want to start a fight. I'm not even going to say anything more than that. The ICU guys in the room are all ready to come up here and start pummeling me, so I leave it as an option. All right, so you've done one of those, you resend your lactate. If it's cleared, great, you're done. If it hasn't, go back, either continue with one of them or pick another one. All right? Any questions about that? Excellent. Now you get to disposition. These patients probably deserve an ICU consultation. They're actually sick. A lot of the times, if you made them look really good by the end of this, ICUs aren't going to take them, in which case put them on a monitored bed. Periodically check. Make sure the map is still good. Make sure they have great mental status. Make sure they're peeing. These patients probably deserve Foley catheters or some form of measured urine output. And what I do is, okay, they look great. I think I've solved their problem. I'm going to send a repeat lactate every 2 to 4 hours. Make sure it's not rising again. That is the non-invasive protocol. I think any ED in the initiative could get this done. And if I'm wrong, email me and tell me why, and we'll fix this, because this is going to be a constant iterative process to make the protocols work for you. Any more questions about non-invasive, or else we'll go to the invasive protocol? All right. So take out your invasive protocols. Same entry criteria. You have those same patients, lactate greater than 4 or MAP less than 65 after getting fluid, and goals of care are aggressively curative. You're going to do basically the same initial resuscitation. You're going to give them more fluid. You're going to send cultures. You're going to think source control. Administer antibiotics to cover any potential source. At this point, you're going to place the full sterile central line in the IJ, because that allows you to use ultrasound, or if you like subclavians, go for it. Harder to use ultrasound for that, potentially higher complication rate, unless you're very experienced. All right. At this point, you're going to look at the patient's oxygen saturation. Less than 90 on high flow O2, which is a non-rebreather mask. You're going to intubate the patient. You've got to be aware. These patients could drop their blood pressure precipitously in these poor cardiac output, non-volume loaded states. So you're going to be cognizant of that. You're going to pre-treat them potentially with more fluids. Or if you have a patient who is borderline and the blood pressure is really low, maybe start them on pressors just for the intubation, see what's going to happen with their blood pressure after, and then you could always turn them off. But I'm very scared whenever I'm intubating a septic patient. You're going to have potentially push dose pressors standing by, and I can send you links for how to do that. Once they're intubated, lung protective ventilation. You're going to put them on a pain control regimen, and they're going to add sedation after their pain is controlled. Now you want to get them fluid loaded. The dynamic IVC ultrasound still works on these patients. If they're not intubated, do it just like the video showed. On an intubated patient, it's a little tougher, And I have a video in the works for that. Because instead of seeing the IVC collapse, it actually is going to expand with the mechanical ventilations because you're increasing the intrathoracic pressure. And it's a much smaller variation. It's between 12 and 16%, depending on the studies you look at. And as a result, you can't really eyeball it. You have to measure. So this is tougher. You might be able to do this if you're ultrasound savvy. We'll get you educational materials to make this happen. But you might say, this is a little bit harder. We're not going to do this at first. So what's your alternative? Alternative is you have a central line now. If you have the potential to do it, CVP is still a viable option. Now, CVP has taken a big hit in the ICU world. Dr. Marek is really trying to knock this one out. But there's potential for this. What I found in the ED is that when I looked at my patients with CVP, they started in the 0, 1, sometimes negative range. Those folks clearly need fluid. And if they get to a CVP of 10 in a non-intubated patient, 14 in an intubated patient, is it going to be perfect? No. But it forces you to give a lot of fluid, which is all I really want to come out of this. And the way it works, and what was kind of ignored in the Rivers trial when they were condemning his use of CVP, was he didn't stop at a static CVP value, which might have been a representation of adequate fluid loading or poor heart contractility. What he did is he wound up giving dobutamine and then going back and looking at the CVP. And what happens in that case is CVP drops when you fix the heart, and he gave more fluid as a result. A very different accuracy perspective than just looking at static CVPs as a measure. So it's there for you. I have videos, which we're going to link to on our website, on how to set up CVPs for any nurses that have no familiarity with this. It's also a lot of fun, and it builds good teamwork to have some ICU nurses come down to the ED and do an in-service on how to set up a CVP line monitoring in the ED. That just gets people knowing each other. It gives a resource so you could call in the middle of the night if you know that ICU nurse you just met is there and actually have people talking. So that's out there. If you have to do empiric fluid loading, that's what you're going to do. But then really, why go down the invasive road? You might as well stick with a non-invasive pathway. You're going to recheck the map. Less than 65, you're going to do vasopressors, just like the non-invasive protocol. All right, here's where it differs a little. When you're checking on your tissue oxygenation, you're going to send lactates and central venous oxygen saturation. All central venous oxygen saturation is you draw a blood gas from the distal tip of the central line. You send it to your lab just like a blood gas. It's better if you can indicate it actually is central venous. Some folks have that capacity, some folks don't. As long as you know and you put it in the chart the proper way, it's okay. But one of the things to work towards is getting your lab to have an order capability for central venous oxygen saturation. Once you get those values back, we're going to ask you to see that both clear. We haven't seen the literature on whether lactate truly correlates with SCVO2. We just know the patient's mortality was the same, regardless of which one you use. There might still be patients who have a cleared lactate but have an SCVO2 that's low. That's telling you they might not be perfusing their tissues. So we're going to try to be as inclusive as possible and tell you you want to see both in this invasive protocol. You want to see both the lactate clearing and the SCVO2 greater than 70. Now you're going to catch all of these patients that still potentially are not fully resuscitated. If those values haven't both gotten where you want them, then it's pretty similar to the non-invasive. Hemoglobin less than 7, easy, transfuse. Additional fluids, especially if you're using CVP, which might not be as accurate. Consider the inotropes. If they're not intubated, and they're at this point, you might want to think about intubating these patients. Intubation takes away the pulmonary metabolic load, which in these severe septic patients, because of cytokine-induced tachypnea, actually is an enormous burden for them. And it's a useless burden. It's wasted respirations. Them breathing at 40 is not because they need to oxygenate. It's because the cytokines are forcing that situation. And that takes an enormous amount of their cardiac output and wastes it. So intubating these patients has been shown to increase tissue oxygenation in a study in critical care. So that's a potential. I tell you, if you show me a 70-year-old with goals of care that are curative because they were playing tennis yesterday in a big match, so I know this is a salvageable patient, I will usually intubate those patients early because they just cannot sustain the things I need to do to them without being intubated. That's my personal opinion. All right, and again, if hemoglobin is between 7 and 10, especially if they're elderly, coronary disease, consider transfusion. You're going to send repeat lactate, repeat SCVO2. You're going to see if what you have tried to do has worked. Disposition, same, ICU consult. These guys probably should go to the ICU. They're even sicker than the non-invasive folks. If not, a monitored bed that can continue checking all the good stuff we need to know that the patient's resuscitation is not slipping backwards. All right. Any questions about the invasive protocol? Excellent. That either means I did a really good job or a really bad one. The last thing I'm going to show you is the resuscitation checklist. This is a bonus. This basically encompasses both of the non-invasive and invasive protocols in a slightly different form. Once you have familiarity with those protocols, you might not want to keep whipping out the protocol. What you might want to do, since these prompts are here on this checklist, is just fill out a checklist for each patient. It also is going to be potentially a data collection tool at the bedside that will allow whoever's going to do the actual data entry on a weekly or monthly basis to collect these forms and actually use them to put the data entry in. So all it asks is time of arrival, time of triage in the ED, was a lactate sent, and then the time you recognized the patient with severe sepsis, which means either they had a lactate greater than or equal to 4, or they were MAP less than 65 after 2 liters of fluid. So you put down that time. It prompts you for the initial resuscitation. It asks you the time of antibiotic administration. And we'll talk about these in more detail during the data collection portion. But all we're asking for this, even though it's not optimal, is the time the first antibiotic touched the patient's vein. Even though that's not really what I want to know, which is the time the last antibiotic finished. But this is what we're asking, time first antibiotic hit the vein. Yes, sir?
Just the absolute spectrum of 4.0 lactate.
Sure.
Talking about just shy of that, what's the thought process?
Yeah, so it's such a fantastic question. The question was, what about that patient lactate 3.9? All right, they don't need to be included in this initiative. But I'll tell you, that patient's really sick. And I aggressively resuscitate that patient. I know I'm not going to get dinged. They don't meet severe sepsis criteria, but those guys are sick. Anything between 2 and 4 has been correlated with increased mortality. There was one study, and this petrifies me, that shows values even greater than 1 have been correlated with increased mortality. Some people even say 0.6. I'm not going to be that draconian. But 2 to 4, I don't send that patient home. I might give them more fluid than would ordinarily. And I tell that admitting team on the medicine service, please watch this patient like a hawk. They scare me. All right? And those patients really should get their lactates trended. Does that answer your question? All right. So SpO2, consider intubating the patient, both non-invasive and invasive protocol, if their SAT is less than 90 on high flow O2. Fluid loading, was an IVC ultrasound done? Was a central venous catheter placed? Which site did you use? Was the CVP measured? MAP optimization. Did you need vasopressors? Tissue oxygenation. Tells you what to do. Repeat the lactate and or the SCVO2. Lactate's not dropping, SCVO2 is not dropping. Optimize using the protocols. And then it's going to ask you, did you achieve that SCVO2 greater than 70? And or did you achieve a lactate decline greater or equal to 10? And then disposition. When did they leave the ED? Not when did you admit them to the bed. We all know, big discrepancy there. No, when did they leave the ED? When did you wave bye-bye? That's the time you're going to put down. All right? We're going to ask you which protocol was actually used. And at the end, did they survive? All right? So that's the checklist. That will feed into the data collection form we talk about later in the afternoon. All right, so that's my bit. I think that the non-invasive protocol, at least, you could go home a month from now, you could be using it on your patients in the ED. I think if you did use it, based on all the evidence that have gone into these protocols, based on my personal experience and the experience of the other folks on the advisory board, this will save lives. I hope it's going to save greater than 10% mortality reduction from what we have now. But I can promise you, if you do this and you didn't have a protocol to start with, every shred of evidence in the literature will tell you you will save the lives of septic patients in your ED. So please do this. If there's barriers to doing it, tell us. We'll fix them. This is the whole purpose of this process, to hear back from you and make it work in your hospitals. So thank you for your attention, and I'll give it back to Zainab.